Welcome to the A New Insight podcast, empowering and inspiring your journey to optimal health. Hosted by Dr. Supatra Tovar, clinical psychologist, registered dietitian, fitness expert, and author of Deprogram Diet Culture. Rethink your relationship with food, heal your mind, and live a diet-free life. I follow my guests' journey to optimal health, providing you with the keys to unlock your own wellness path. Tune in and evolve with us. Welcome back to the New Insight podcast. We're back for the second half of our incredible interview with quadruple board certified psychiatrist and founder of Wellness Psychiatry, Dr. Vikas Gupta. Dr. Gupta gave us, oh my gosh, so much insight into some of the recommendations, some of the pitfalls, some of the worries about medicalized treatment for weight loss. I am very excited to learn more. Vic, welcome back.
Thank you so much. I'm so elated to be back.
Yes. So we have a lot of people who are finding their medications. They cannot get, or their doctor will not prescribe them the medication. And so they're going to compounding pharmacies, which we've seen kind of go through the gamut of, being told that they need to shut down now that Novo Nordisk has a greater supply. But what I've actually seen is that they've just switched their formulation, added some things so that they can get a workaround. What should patients do if they're, feel like their only choice is to go to a compounding pharmacy? And how do they even know what they're getting? What are some suggestions for people who are looking to find their medication in that route?
Oh, it's a great and timely question. The regulatory tightening we've seen now is largely about making sure their medications are safe and consistent. As you are aware, that the compounded versions fill the real gap in the supply of these medications. But the concern was that not all of these were being produced under the same quality standards as the other FDA-approved products. And for patients who've relied on the compounded GLP-1s, I recommend 3 practical steps. And before I recommend that, I also want to preface that with saying that the FDA does not support the use of compounded GLP-1s because there's no way to ensure their quality standards. That said, if you're struggling to receive FDA-approved medications and relying on GLP-1s, I think these 3 practical steps could be helpful. So the first is to talk early with your prescriber or your obesity medicine specialist or your endocrinologist, whoever is prescribing the medication. Don't wait till your vial runs out. Planning ahead prevents abrupt interruptions. The second, I would say, is to explore manufacturer access or savings programs. So, like many branded medications like semaglutide or tirzepatide, they have patient assistance pathways, especially for continuing the continuation of treatment. So, exploring that would be relatively helpful. Third is if you may have to pause temporarily, focus on maintaining your metabolic scaffolding, which means structured meals, hydration, balanced food intake, and resistance training. The key message is don't panic, but plan. Your physiology doesn't vanish overnight, and healthy habits can bridge the gap till the medication access returns.
Yes. Here's something I also see is that people, when they get their medications from these compounding pharmacies, they have no idea how to manage the dose. They don't know. They're posting pictures of the syringes and saying,
Uh-huh.
hey, everybody, asking the metaverse what their dose should be based on their syringe. Would you suggest, because it frightens me that having anybody, who's not a doctor tell me what I should do with my injection. Do you suggest they actually go to their doctor to ask them, even if they've gotten it outside of a prescription to make sure that they're doing this safely? And would doctors be amenable to helping them figure out that dosage, even if they're not prescribing it?
So there are prescribers and doctors in the community who are prescribing compounded versions of GLP-1s. Many of their patients are not comfortable with these injections, and some of them are also providing assistance in their clinics to do this. Um, that said, even the prescribers and doctors, they don't have first-hand knowledge of the compounded versions. So while they're able to do that, but it does come with a disclaimer that they still don't have like quality control over what is being administered. So I think it's like a risk benefit discussion that the patients can have with their doctors. The doctors sometimes are privy to the compounded pharmacies in terms of their prior tech records and in terms of any response, bad response, or adverse effects that any of the patients have reported. But that is again a smaller sample size. But that said, I think either way, a good discussion with their prescribing physician is relevant and very important.
Yes, I think it says a lot about the pressures that people face in our society, that there's so much damage done from weight stigma. And when people experience being overweight, the motivation to go outside of our medical providers to get something like this at the risk of their health. It just says everything to me about our culture and how much we need to change, how much we need to stop focusing on our weight as a number or as a moral value, or a measure of our worth. If we have to go to these compounding pharmacies and we don't know what we're injecting into our bodies, that that's just taken us so far away from health and so much more towards unhealthy pursuit of thinness. And so I hope people hearing this know that there's other ways that we can improve our health, and that your weight does not equate to your worth. And working with a psychologist will be very helpful as you are pursuing your health journey. Because if the only focus is on thinness, we're in big trouble, you guys. We're in really big trouble.
Yeah.
So let's talk about people who don't react to the medication. They may not lose weight at all. They might even gain weight despite being on them. What are some of the biological or behavioral reasons that might happen?
So absolutely, this can happen, and it's more common than what people may think. Uh, Few reasons. Biologically, not everyone responds the same way to medications. Um, some individuals have different GLP receptor expressions or metabolic adaptations that may cause and contribute to this. Sometimes the issue might be the dose is too low and they didn't see their physician for a long time and did not follow up for a year, and um, as a consequence didn't lose any or much weight. Sometimes the titration is too fast or going up on the dose too fast, and that can maybe result in some side effects, and because that people may want to not take the medication anymore. And sometimes the impact of other medications, antidepressants or beta blockers, may blunt the effects of some of the medications. The other variables that may play a role in this is sleep, inflammation, and thyroid function. They may also impact the medications not working in the same efficacious manner as they do for so many other.
Mm.
The other thing, which you aptly mentioned before, is behaviorally when the appetite drops, the protein intake, carbohydrate intake, and the movement often drop as well. And in turn, people may lose lean muscle. The metabolism may slow down. They eat less, but also move less, and their progress may plateau. So I frame success from weight loss to metabolic resilience. Focus on preserving muscle, maintaining energy, and building sustainable habits. It's not always that the medication isn't working. It's also sometimes that the body isn't adapting.
Yes, and I'd like to add, especially if the dosage is too high. And this is the same case if you have a highly restricted diet. Our body is evolutionarily designed to resist starvation. So it goes through a lot of processes when it senses extreme restriction, which is what we see a lot of times with these medications, but just even restrictive dieting. And what the body will do is it will slow down thermogenesis because it's trying to hold on to those juicy fat cells, and maintain those calories so that they can use them for energy at the at in terms of like in an emergency situation. The body tends to prefer, of course, carbohydrates, but we'll use fat if there's no stores available. But it will slow that down when we are in a highly restrictive diet. And it will also, there's this thing called the body energy partitioning system where it will keep track of how much muscle you've had, how much fat you've had before the restriction, and it will try to rebound you right back to where you started from if you were in restriction. But when we are in hormonal balance and listening to our hunger, listening to our fullness, eating slowly throughout our meals, and especially eating foods that the body thrives upon, which are mainly carbohydrates and healthy proteins, especially plant proteins and healthy fats, the body then does not feel like it is in this restriction, starvation mode and can utilize those nutrients more efficiently, doesn't hold on to your fat. It starts to burn it off slowly and sustainably. So that's how you can actually avoid dieting completely, or you can wean yourself off of these medications with this knowledge so that you do not have to be on these medications for life. And I think that that's something that a lot of people are striving for, and what I hope to really blast out as information through this podcast and my speaking engagements and things like that. So I really want to talk about other medications. But before we do that, I would like to really delve into the topic of eating disorders and disordered eating in relation to these medications. I just recently delivered a TED talk because I was so alarmed to see the dramatic rise in disordered eating and eating disorders. And you're actually doing some work with Montanito right now, and I want you to help give everybody a picture of some of the things that we're seeing come from GLP-1 use and these medications. What are you starting to see in terms of eating disorders and disordered eating, and how can we mitigate against this?
Right. So, first of all, whatever I say is not endorsed by Montenegro, uh, but it's coming from my personal opinion. So, as regards to eating disorders, they present like a complex, overlap with the and concern for the GLP use. So, we do see patients who begin to get disordered eating after they are on GLP-1s because of um, aberrant cues and perhaps decreased appetite, um, and that can sometimes stimulate disordered eating. With the eating disorders, we have an array of patients who already deal with restrictive eating behaviors, and on occasion, many of them may have like binging episodes, and sometimes they may pursue GLP-1s for the binge eating with their providers and doctors. So I think it's very important for the physicians to carefully and aptly ascertain if there is any restrictive eating or restrictions happening outside the binging, because in that scenario, and if the uh, concern is for the anorexia or other specified eating disorders, which are atypical of like a typical binge eating scenario wherein the BMI is more than 25 and binge eating is the only presentation. I think the physicians need to be very careful about prescribing GLP-1s in patients with disordered eating and eating disorders. They're certainly not recommended in anorexia or other specified eating disorders, especially if there's any component of restriction happening. We also have to be very careful about prescribing these medications in patients who have a history of anorexia or disordered eating, even if they are fully stable at this point. So I think there is a risk balance, a risk benefit analysis that needs to be done, aside from taking a detailed history before a prescription of these medications. I
Yes.
do, I do know that a lot of patients um, consider the weight as one of the primary, assessments of how they see themselves and in terms of their body image and self-image. And oftentimes we do see patients asking for these medications. I think the onus is really on the doctors and the prescribers and the therapists that they work with to carefully assess them for any history of disordered eating or eating disorders, and carefully and educationally inform their patients about the relative value or their potential to hurt their particular scenarios.
Yes, and I think that that's very difficult with a lot of these online prescribers where you can just fill out some kind of questionnaire. There are so many ways to fake your answers so that you can get these medications. So I think we're in the wild, wild west right now in terms of how disordered eating and eating disorders can be completely exacerbated. I just read a study that, GLP-1s are significantly associated with patterns of misuse, which could be unprescribed use, intentional misapplication, other ways that are really disturbing for what we're seeing right now. And I know that there's been essentially an unprecedented rise in eating disorders related to these medications. So,
Mhm.
can you give a clearer picture of how an eating disorder or disordered eating might occur with somebody while on these medications? What would be some of the factors that lead them down that road?
So sometimes, it's obviously the GLP-1s lower the appetite. So with someone who has a recovery from an eating disorder previously, um, but they're not satisfied with their body image, perhaps they have a BMI of 22 or 24, and they visit their online prescriber, and they don't answer honestly regarding their BMI, their weight, and there is alleged risk that they may be prescribed one of these medications, which may foster restrictions again and may lead them to a relapse of their eating disorder.
Mm,
Um, I think the overall assessments needs to be thorough in terms of like the weight, the BMI, the prior eating history, the prior history of any eating disorders or any treatments in any kind of settings, residential, inpatient, outpatient, intensive. So I think the history really needs to be thorough. And I have seen a lot of patients who have come in with concerns for occasionally, say, binge eating with a higher BMI, but they've had a history of restriction previously, and because eating disorders can also evolve over time.
mhm.
So I think the onus is really on the doctors to monitor the eating with the weight and the BMI as well. Uh, Obviously, it's easier done in the programs where there is monitoring, like in a partial program or a residential setting where diet is monitored and food is monitored and intake is monitored and meal completions kind of are noted and ascertained, and patients get feedback all the time. However, in an outpatient kind of work, this is really going by what the patients are telling us. So, but the only objective metrics we have are the weight and the BMI, and kind of seeing if there are other concerns like low heart rate, low blood pressure, dizziness. Some of those variables can actually play into disordered eating, and if someone is actively restricting. So, monitoring for the physical factors, the objective factors, the vitals is critical with the use of these medications, and even when considering them.
Yeah, and I would say that that's a lot of pressure for a doctor to be under. And I think that just calls for a more multidisciplinary approach. I
It does.
think, like you and I would be the perfect team because we have you as a psychiatrist and me as a dietitian and psychologist. Like, I think that people need to understand that these medications can be very dangerous, that it's not just a magic pill, that you can't just inject yourself, eat whatever you want, and or just not eat, which is even more frightening, and then lose weight and everything is going to be okay. These medications are extremely serious. They
Mhm.
can cause some real debilitating side effects, and we shouldn't just be injecting ourselves with things that we don't know, especially from these compounding pharmacies. So, it also speaks to the broader cultural issues that I was talking about earlier. And I think the disordered eating and eating disorders get exacerbated because people feel it's okay to comment on other people's bodies, whether
Mhm.
it's you're too fat or you're, oh, wow, you're thin. And either one of those comments can exacerbate disordered eating or eating disorders. And you're not even aware that you're doing that, especially if you're complimenting someone's weight loss and they're on these medications. You might be feeding into something that is going to be ultimately deadly for that person. So I
Mhm.
think, yes, we need to all be working together, and we need to get some more education out there on how do we talk? Do we talk about each other's body? I personally have a staunch rule that we don't make comments about each other's
Mhm.
bodies because we don't know if we are complimenting an eating disorder. And we certainly do not weight shame, which we
Mhm.
still see, especially in doctors' offices. I have to say, doctors' offices are some of the areas where we need to really educate doctors on how to speak to people in terms of their health more than their weight, because weight doesn't always equate to poorer health. So
Absolutely.
we have a lot of things to change. Would you agree?
Absolutely. I think the movement of health at every size is picking up, and there's a huge conversation around that. Unfortunately, it hasn't translated as such to the medical settings, which still heavily rely on like BMI as an indicator of health. So
Yeah.
you're absolutely right. There are very, very healthy people who are sometimes occasionally a very high BMI, and
Mhm.
BMI isn't or the size isn't an indicator of physical, emotional.
Exactly. Exactly, and I think that that's, for most people when they go into a doctor's office, their first fear is being weighed by the doctor and then being told, "Hello, your BMI is blah blah blah. And you need to diet and exercise." And I think we need to get away from that and ask deeper questions. And it's really hard for doctors. I will, be sympathetic that they don't have a lot of time. They also don't have, some of these measures to really help people, but there are some simple questionnaires that you can give to your clients, like the Eat 26, where you can really start to understand people's eating behaviors. And I think encouraging this open, honest conversation in the office, avoiding the weight shaming and the weight stigma, and really helping somebody on a more of a holistic level rather than just here's some medication, now just go and eat high protein, low carb. Like, let's get away from that and really start to look at a person individually. um, let's also talk about like other medications while you're on GLP-1s. How do they interact with like psychiatric medications like SSRIs or mood stabilizers or antipsychotics?
Yeah. So the good news is that true drug-drug interactions are rare with these medications, but there are functional overlaps to watch because they slow down the digestion. Sometimes we notice that the oral medications like SSRIs may not absorb as well, and they may absorb more slowly. Uh, Taking the SSRIs on an empty stomach can also worsen nausea. So, also for patients who are on antipsychotics, which sometimes may cause weight gain, GLPs sometimes can actually help rebalance the metabolism. So I also work in inpatient settings in both the children's inpatient units, and they're being used for patients who gain quite a bit of weight on antipsychotics to kind of counterbalance that. So that is a real possible benefit, but we do have to monitor for hydration, energy levels to avoid you know sudden drops in glucose or mood stability. We also have to watch out for other potential side effects that can happen because of GLP-1s, like nausea and constipation, as we talked about before. Um, in other conditions like bipolar disorder, rapid physical changes can sometimes be destabilizing for mood rhythms. So it's very important for communication between obesity medicine physicians and psychiatrists and anyone who works in this space. Um, I often say that the brain eats what the body says, and when the body changes its rhythm, the brain can feel it also. So um, some of these interactions somehow can impact your moods, your emotions, and being on concurrent medications can sometimes be a concern, and they need to be watched very carefully.
Yes, more need for multidisciplinary care for sure. One question back to eating disorders. I have been reading that GLP-1s are not recommended for binge eating disorder. And I just really want to make sure that we talk about that before we end this podcast. What are your thoughts on all of that?
Yeah, great question. So I think the binge eating disorder, there are some FDA approved medications for that, like Vyvanse or is approved for the binge eating disorder. Sometimes we'll use Topamax in binge eating disorder, so that's another alternative. Then there can be other alternative medications that can be tried. On occasion, if everything else has failed and someone really has a true binge eating disorder and a heavier body mass, and they have other metabolic complications like high blood pressure, high cholesterol, diabetes, for that matter, they may be an acceptable, option with a high BMI. But if binge eating is accompanied with restriction and a lower BMI below 25, and there is significant concern for disordered eating and restriction and a history of anorexia, certainly GLP-1s can actually trigger way more problems than benefits. So, um,
Exactly.
yeah, so I think this should be used as a last resort in that scenario, and only when binge eating disorder is an actual diagnosis. Oftentimes, we see that binge eating is happening in the context of a bigger eating disorder picture with restriction, and patients are asking for a medication, and they come with diagnosis of binge eating, but it's not actually true binge eating disorder. It's actually binge eating in the context of restriction, which is not diagnosed as binge eating disorder, which is other specified eating disorder, and GLP-1s are certainly not recommended.
I will agree wholeheartedly. Many of my clients who've come in for difficulties with binge eating, I have seen it stem from a restrictive dieting mentality, along with a lot of other psychological factors. And that's the other area that I just want to emphasize for people that there are many complex reasons why we develop problems with eating. It's not a strictly physiological problem. Most people who struggle have had some kind of trauma, difficulties in childhood, come from abuse, maybe even from poverty, have some distorted views on sustenance and its need. There's so many reasons. So I would say that, if you are struggling with binging, and especially if it's coming from being in a dieting mentality and not being able to handle that or control that anymore and swinging over to binging, these medications are not going to help you. They will definitely exacerbate that restrictive cycle, which then we see, especially if you get off those medications, contribute to the binge cycle. So it is so important to talk to somebody who can help you work through these issues. A therapist, a psychologist will be your best bet in that area. And then you can also work in a multidisciplinary approach if you really want to improve your eating. Going to somebody who's a Hayes um, aligned dietitian will also help you because they will keep you away from that dieting and restrictive mentality and provide you the dietary education that you will need to improve your overall health, which may include your weight and it may not. It just may just improve overall physical and mental health. And I think that's what we really need to emphasize on some more. So for you, Dr. Vikas, what is down the pike for you? Where do you plan to take your practice? And what do you see for psychiatry in general in your area in the future?
Yeah. Thank you. Great question. So I'm very optimistic about the future of psychiatry and mind body medicine in general. I think we are headed towards a true mind body convergence model with so much conversations and overlaps and how the mind body connection is being studied. Um, I expect in the next 5 to 10 years quite a few major shifts. One, I anticipate that personalized psychiatry will meet a lot of metabolic data. There'll be a lot more genomics, microbiome testing. There'll be also a lot of wearable technology that may help match treatments to emotional and metabolic profiles. Then, as you already mentioned, there's a lot more uh, understanding and importance of multidisciplinary treatments and a lot more integrated care teams, including dietitians, obesity medicine physicians, psychiatrists, and therapists will be working together, not in parallel silos as they do mostly now. Um, and then I do also think that metabolic mental health will become mainstream. We'll see that nutrition, inflammation, and circadian rhythm are treated and discussed as primary levers for mood disorders, not as side notes. And the future really will belong to clinicians who can read both the lab values and the life stories, and treat patients with compassion and really utilize the precision medicine and other medical advances that might happen in the next few years.
Yay! I'd love to hear that. When I was interviewing for my doctoral program and I was coming out of my nutritional science program, the person interviewing me asked why I was going in a different direction. And I was like, "What?" I was like, "What do you mean?" I'm going in the same direction. And I think that that's where we're seeing a lot more people becoming aligned with nutritional psychology and psychiatry, that our physical health is 100% connected to our mental health and vice versa. And if we can understand what food, all these lifestyle factors can do to help or harm us, we can improve people's health. So I love to hear you say that. And I love how aligned you are with me. It's been such a pleasure to sit here with you, Vic. I just think you're a wealth of knowledge. You're such a kind, compassionate, and gentle person, and you really do have a wealth of knowledge. So, how can people find you? How can they work with you? Give us all the 411, please.
Absolutely. Well, the best way to get a hold of me is through our practice website, wellnesspsychiatry.com. We offer telepsychiatry and holistic wellness consultations for adults and adolescents, as well as children in several states, including California and New York. And today it's been a enlightening and practical conversation. I really appreciate you inviting me. Thank you.
Oh, absolutely. And I would love to have you back on here some more and pick your brain some more because you are just incredible wealth of knowledge. So, you guys, oh my gosh, we were blessed today. Thank you, Vic, for coming on the podcast. I am so grateful. And thank you, everyone, for tuning in to the A New Insight podcast. I'm looking forward to the next exciting interview and really hope you join me next time. Thanks for tuning into the A New Insight podcast. Please remember the contents shared on this podcast is for entertainment purposes only and does not constitute medical advice. You can find us anywhere podcasts are streaming, on YouTube at my.anu.insight and at anu-insight.com under the A New Insight podcast tab. And follow us on our socials at my.anu.insight on Facebook, Instagram, TikTok, and Threads for more updates. Tune in next time and evolve with us.